Hi everyone. As part of the AIOS Step-by-Step MIGS All India Ophthalmological Society Educational Module, I, Dr. Aparna Rao from LV Prasad Eye Institute, Hyderabad, will be presenting a brief outlay on the intraoperative predictors for clinical outcomes after MIGS. Before we dive into the success indicators for MIGS, I would like to emphasize the importance of the journey we all must undertake to achieve the best outcomes for our patients. We should endeavor to first develop optimal hand and lens coordination in our routine glaucoma or cataract cases, as this enables steadiness of the hands during surgeries. Once we have mastered this, we can progress to simpler procedures like band, goniotomy, and syneculisis before embarking on more challenging techniques of MIGS for our patients. We also need to clearly formulate the desired outcome indicated by the specific MIGS surgery for each patient, outline and justify the preference for MIGS over trabeculectomy versus other MIGS procedures too, weigh the possible risks involved in the procedure, and also be well informed about the best long-term outcomes of the specific surgeries in existing current literature. Now that we know the various MIGS procedures available and their outcomes, what are the different ways in which we can assess surgical success, either intraoperatively or postoperatively? We can assess the outflow pathway using gonioscopy, the gold standard, which only enables visualization of the trabecular meshwork and the Schlemm's canal, but not the distal outflow pathway. The latter can be visualized using either fundus fluorescent angiography, OCT angiography, or the aqueous angiography, and to some extent using the anterior segment OCT. OCT angiography and aqueous angiography help in the visualization of the arborization of the vascular plexus in each eye at various stages of the surgery and also after surgery, which is crucial to understanding the impact of our surgery on the outflow pathway and its influence on the intraocular pressure. Before we dive into the intraoperative predictors per se, let us now understand the anatomy of the outflow pathway components. The superficial venous plexus is part of the conjunctival and episcleral veins located near the ocular surface. It drains aqueous humor from the collector channels of the Schlemm's canal, which then flows through the intrascleral venous channels deep into the sclera. These veins contribute to the conventional outflow pathway, which is a primary target for most MIGS procedures. There are 25 to 35 collector channels in the eye with maximum concentration in the inferior and the nasal quadrants, which is why MIGS is often performed in the nasal region. A few of these channels are also connected to large venous emissaries, namely the aqueous veins of Asher. It's important to understand that dynamics of aqueous flow through these channels are impacted by any surgery that causes a differential in pressure across the outflow components. Right from the trabecular meshwork, the Schlemm's canal, the collector channels deep down to the scleral plexus. Therefore, we must consider the potential effect of our surgery and the effect of the surgery on the episcleral venous pressure or the flow dynamics after the surgery, as these may eventually affect the final intraocular pressure achieved. Additionally, we should be aware of the potential trauma from forceful gripping of the trabecular meshwork, passage of a suture or microcatheter, which can cause bleeding and recruit fibroblasts into the region, potentially leading to closure of the mouths of existing collector channels in that area despite a successful surgery. I routinely perform microincisional trabeculectomy or a suture gap for most of my patients. While the techniques described in this presentation do work and apply to these two procedures, I would request the viewers to test these techniques in their own specific MIGS procedures and evaluate the results in their hands. Microincisional trabeculectomy ensures minimal hyphema, fewer complications, and a better safety profile compared to GAT while achieving comparable and adequate IOP control when compared to other MIGS procedures too. Microincisional trabeculectomy involves a gentle stripping of the trabecular meshwork. The steps include an initial goniotomy incision using an MVR blade, with the difference that this incision is carried out from 3 to 5 clock hours, as seen in this video. After a goniotomy incision, I do perform a horizontal light incision to separate the iris strands from the trabecular meshwork, which may cause damage to the iris while the trabecular meshwork is removed. This step is now followed by two vertical cuts on the edges of the delineated region, as seen here using a 25 gauge micro scissors straight angle. This ensures that the strip that we have delineated by these two vertical cuts, when stripped away, does not extend to the adjacent regions. After vertical incisions are given, now with a 23 gauge micro forceps, I gently pick up the cut edge and then move the trabecular meshwork and strip it gently off from the Schlemm's canal, and this gentle stripping ensures very minimal bleeding or damage to the iris, minimal contamination of the cornea or the sclera, and a no-touch technique to the Schlemm's canal, because no instrument actually goes into the Schlemm's canal after the goniotomy incision. The success of any MIGS, including MIT or GAT, is often reflected in the presence of a white ridge that represents the deroofed Schlemm's canal after the trabecular meshwork is removed, or in the form of a residual trabecular meshwork leaflet that is seen guarding the Schlemm's canal in GAT. Gonioscopy can also help us identify an open ridge versus a closed one in the postoperative period that may be closed by fibrosis or even by PAS. ASOCT and gonioscopy also help us identify adverse effects of the procedure, such as hyphema, peripheral anterior synechia, and scarring responses that can be seen at the angle, as is reflected in these images. Therefore, it becomes imperative to look for intraoperative predictors for success to achieve better outcomes in the postoperative period, rather than relying on postoperative ASOCT and gonioscopy. Use of intraoperative predictors may help us achieve better surgical outcomes for almost all our MIGS surgeries. Intraoperatively, we can assess the outflow pathway in easy methods. One of the most commonly used is the episcleral wave that is caused by pushing saline forcefully into the drainage angle in a specific region with force that blanches the episcleral vessels, and therefore making the sclera in that region appear white, as seen in this top panel. This can be followed up by use of visible dye like trypan blue to stain the veins that are draining the specific angle region. As we can see in the middle and the lower panel, the veins have been highlighted and colored blue by the trypan blue going and seeping through these veins. In our In our earlier study evaluating these two techniques, we observed four different patterns of staining, namely superficial pattern of staining, a deep episcleral venous staining, reticular or net-like staining, and the fourth, a diffuse pattern of staining where there is a bluish hue that is visible rather than a particular vein getting stained. We also found that staining in more than 2 to 3 quadrants of venular staining was associated with a reduced need for medications for IOP control in the postoperative period rather than predicting the need for complete surgical success. Additionally, we observed a variation in the extent of blanching and the venular staining in some eyes as highlighted in these photographs, suggesting variability in the drainage pattern in each and every eye. So let us see some videos of these two techniques. The first video shows the formation of the episcleral veins which blanches the episcleral vessels in the quadrant where I push the saline, causing disappearance of the vessels and whitening of the sclera in that region. This is usually followed by trypan staining using trypan injection into the anterior chamber under air bubble. You can see that this causes visualization of many superficial as well as some of the deep veins as we can see in this video. But important to note that while the blanching and the staining in this video correlates and matches happen in the same area, the blanching and the staining pattern is rarely simple as seen in this case. This video showcases some variations that may be seen which may cause confusions. This video suggests and shows a blanching that you see immediately in 3 clock hours, as can be seen by whitening of the sclera and disappearance of the superficial episcleral veins. However, the venular staining now is seen to be restricted to only 1 or 2 superficial episcleral veins, while the rest of the area remains blank. Further, this video now showcases that the blanching that happens immediately after a forceful injection now extends after continued injections into more than 5 clock hours, as can be seen in this video, suggesting that certain collector channels have a pressure differential or a critical pressure for opening up. And to add to the confusion, we also have a staining that is seen to be restricted in a very diffuse pattern in a small area despite the extensive blanching seen almost over 5 clock hours in this eye, as can be seen here. In summary, the extent of blanching of the area does not always match perfectly to the extent or the pattern of venular staining with trypan blue in all the cases. This suggests a lot of regional anatomical variations in the pattern of draining vessel plexuses in each eye that we are yet to understand. These might also change after surgery dynamically due to fibrosis in the region over time. That may again impact the final surgical outcome. We also do not have a robust method of visualizing the aqueous veins by any procedure so far. We also have to keep in mind the collapse of existing collector channels in the surgical region owing to changes in the pressure dynamics due to the surgery, which again has a bearing on the final outcome, even though the intraoperative indicators would have been favorable for that case. One more new method for assessing the effect of surgery is intraoperative OCT. This enables us to see the visualize the Schlemm's canal being deroofed as we remove the trabecular meshwork in microincisional trabeculectomy, or help assess the bleeding that occurs into the angle from the collector channels in specific regions, as seen in the above images. However, it's a very challenging procedure to keep focus on one region during the entire operation or the steps of the surgery, since it requires constant focusing by an experienced technician should show the effects at each area as the surgery proceeds through every step. Aqueous angiography and OCT angiography are new techniques that allow us to visualize not only the distal outflow pathway during surgery, but also demonstrate the recruitment of new vessels in the region of the surgery, suggesting a favorable outcome. Intraoperative predictors may be impacted by the scarring responses at the angles as we alluded earlier. This can be seen very well and documented on ASOCT, as seen in these images. This should be kept in mind to understand the overall impact of the surgery and tailor our management on review accordingly. In our earlier study, we did find various grades of scarring as can be seen in these slides, ranging from mild, moderate to severe scarring that can be seen in the region of surgery that used to happen in three distinct patterns, which include an open saucer, a closed saucer, or a filled up trench pattern. What was interesting in our study was that severe scarring in a trench pattern seemed to predict the need for medications for IOP control, though they did not independently seem to influence the final IOP or the surgical outcome. This again indicates the importance of anatomical variations in each eye and the dynamic changes that happen in the pressure flow dynamics in that eye over time that at present are not amenable to easy assessment by any technique. To conclude, intraoperative predictors can help gauge the need for medications but cannot fully predict long-term success. Dynamic adjustment of IOP goalposts based on routine clinical follow-ups and other adjunctive tests like gonioscopy, ASOCT, OCT angiography, or aqueous angiography are key for ensuring long-term success. Future innovations, such as the use of Doppler or other methods, may evolve for studying the outflow pathway in more detail. But we should remember that the ultimate goal for any filtering surgery, including MIGS, is not just adequate IOP control, but maintenance and preservation of visual function, which must be monitored over time in all the patients. Thank you.